especially in Africa and Asia, millions of people rely on shared sanitation as part of their daily reality. And yet shared sanitation continues to generate important debates across the sector, particularly around health outcomes, service quality, and its role within urban sanitation systems. Today's webinar contributes new evidence to that discussion. Good afternoon, good evening, and good morning to those joining us from across the globe. A very warm welcome. We'll pause briefly to allow a few more participants to join in. And as we do, please introduce yourself in the chat, your name, your organization, and where you're joining us from. Great to see so many of you already connecting. Thank you for being with us here today. Once again, welcome. My name is Florence Lake from the International Water Association, and it's a pleasure to moderate today's session on shared sanitation, child health. This webinar is co-convened by Water and Sanitation for Urban Populations and the APHRC CWISE Network. Today's conversation sits at the intersection of urbanization, inequality, and child health. We will explore new evidence from the Maputo Sanitation, that's its MapSan trial, which is the first rigorous controlled study examining the health and quality of life impacts of high-quality shared sanitation in low-income urban settings. The 60-month follow-up of findings are significant for the sanitation sector. Importantly, we will reflect on what these findings could mean for policy, programming, investment, and future research. And over the next 90 minutes, we will explore we'll move through 3 steps. One is in understanding the evidence, interpreting what this tells us, and exploring how it can shape decisions going forward. Let's begin by looking at who will guide us through this conversation. From the screen, we have an excellent lineup of we've structured, next slide, please. Yes, we've structured this session to be dynamic and interactive, combining presentations, polls, the panel discussion, as well as the Q&A. We will begin with presentations unpacking the key findings from the MapSan trial, from child health outcomes to quality of life and mental well-being, and then to implementation insights from the field. And building on these presentations, our expert panel will explore the broader implications of these findings from research, programming, investment, policy, and advocacy perspectives, with particular attention to the intersection of WASH, public health, and child development. However, before we begin, I would like to share a few housekeeping points or housekeeping notes. We encourage active participation throughout the session. Please use the Q&A box to submit questions, and also use the chat to share your reflections and comments. Our team will be curating questions and will bring some of them to the panel discussions as time allows us. Please note, microphones will remain muted, and also the raise hand feature will not be used. However, the session is being recorded, and we'll share this recording along with any presentation materials afterwards. With that, let's set the scene. Now, to ground us in the regional and regulatory context. Next slide, please. I'm pleased to invite Yvonne Magawa, the Executive Director of ESAWAS, and also the coordinator of the APHRC CWISE Network. Yvonne, over to you.
Thank you very much, Florence. I hope I'm audible.
Yes, you are. You are audible.
Yes, you are. You are. Thank you very much. So this webinar is convened under the umbrella of the APHRC Citywide Inclusive Sanitation Network, APHRC CWISE Network. The network is a collaborative platform to accelerate the adoption and implementation of the CWISE approach across the continent. The network, which is anchored under ESAWAS, has brought together a diverse group of multi-country stakeholders. These include development finance institutions, regulators, research institutions, development partners, service provider associations, technical partners, and regional and global networks. Why are we coming together? This is to drive the momentum towards meeting sanitation aspirations for universal access and quality services across the continent. The network aims to strengthen collaboration and coordination across actors. We have recognized that for a long time we have worked in silos, and we're saying it is time to change that narrative, and we should not work in silos anymore. We also want to amplify shared learning, co-creating knowledge and sharing these across institutions and countries. We also want to foster unified actions and efforts. Instead of duplication and overlapping efforts, we want to synergize those efforts. What is our end goal? Is to enable the delivery of inclusive, safe, equitable, and sustainable sanitation services at scale and impact towards attainment of SDG 6 and the country aspirations. So this webinar represents a very good example of unified working for sanitation. And we are honored to host this under the Africa Citywide Inclusive Sanitation Network with our partner, one of our partners, WSUP. Thank you very much.
Thank you so much, Yvonne, and for that overview of the Africa Citywide Network, of course, as a platform for coordination, collaboration, and shared learning across the sanitation sector. Now let's hear from Anthony Ambugo, who is the Kenya country manager for WSUP, and he'll share with us reflections from WSUP's perspective as an implementing partner of the MapSan study. Anthony, over to you.
Thank you, Florence. Yeah, my name is Anthony Ambugo, the country manager for water and sanitation for urban populations. Before I joined WSUP, I was managing director of 2 utilities for 6 years and also the chief executive officer of water and sanitation service providers for 7 years. So I've been in the sector for almost 1.5 decades. So for those who are not familiar with WSUP work, we are a non-profit specialized entity in urban water and sanitation systems. We were established 20 years ago to address one of the world's most urgent challenges, ensuring safely managed water and sanitation for all city residents within the urban wash ecosystem, but with more specificity to those who reside in low-income and informal settlements. How do we prosecute this? Our entry point in different countries is always the mandated service authority that is responsible for providing these services citywide. We work in close partnership with these authorities to test new approaches like MapSan and to strengthen policy, institutions, regulations, and financing to take these approaches to scale. Through these partnerships, we have established a long-term presence in 7 countries, 6 in Africa and Bangladesh. We have also supported citywide inclusive sanitation approaches across these locations. We have reached at least 44 million with improved wash services, including over 10 million people with better sanitation. So we are an implementer, but we also work at the interface of research and practice. Research is core to our theory of change. We believe in testing context-specific solutions and leveraging our interventions to build the evidence base and influence the sector at regional and global levels. This brings us to the MapSan, which you will hear about today. We are honored to be the implementing partner in this landmark study with our research partners at Mozambique National Institute of Health, University of North Carolina, and London School of Hygiene and Tropical Medicine. You will hear from the research team and a panel of experts on the results and the implications. At this juncture, please allow me to briefly share WSUP perspectives, these findings, and how we intend to build on them. We have convened this webinar with our research partners and with the Africa Seawise Network because we believe this evidence demands to be heard. WSUP has known for many years that high-quality shared sanitation is key to delivering sustainable and inclusive sanitation citywide. The reality of densely populated low-income urban communities means that there is no alternative. And thanks to MapSan, we all know that if delivered to a high standard and well maintained with strong municipality and community engagement, these facilities can deliver life-changing impacts in child health, first of all, but also in quality of life, especially for women and girls who take the disproportionate burden. Taken as a whole, the findings provide the foundations for complete and powerful evidence base supporting high-quality shared sanitation. This is why, together with our partners, WSUP is committed to advocating for and delivering high-quality shared sanitation at a much greater scale. Last year, we launched our new strategic plan, 2025 to 2030, and MapSan evidence is reflected at the core of this plan through our initiative, Shared Toilets for Improved Child Health. We will continue to build this evidence base and to innovate in this area, including the program I manage in Kenya, where we have deployed simplified sewer systems in the past in 3 cities, that is Nairobi, Nakuru, and also Naivasha. We intend to escalate the learnings from the MapSan findings and have a specific focus on how this can be scaled up. Penultimately, allow me to thank ESAWAS as coordinators of the Seawise Network and our research partners for collaborating in today's session. The MapSan evidence is, of course, complex. Finally, we are excited to hear your reflections from all of you on how these results should be acted upon. We hope today's discussions can shed light on what MapSan means for sanitation, health, and urban development, and how we can work together as part of the Seawise agenda and across sectors to ensure this evidence leads to better sanitation and better health for millions and more. Thank you.
Thank you so much. Thank you so much, Anthony, particularly, of course, for highlighting the realities of delivering inclusive sanitation services in rapidly growing cities and the importance of combining implementation, research, and partnerships to strengthen the evidence base and scale impact. You also reminded us that the discussions around shared sanitation must ultimately be grounded in the lived realities of low-income urban communities, and of course, the need for cross-sectoral collaboration. Now, before we turn to the evidence itself, let's hear from you, our participants. We would like to understand your perspectives on shared sanitation in the global context. I now hand over to Sam Drabo, the Director of Research and Evaluation at WSUP, to guide us through our first poll. Over to you, Sam.
Great, thank you, Florence. I hope you can hear me okay.
Yes, we can hear you.
Okay, so fantastic to see so many of you on the call, and thank you so much, Yvonne and Anthony, for those powerful openings. So my role is going to be popping up intermittently through this session to hear from all of you, because we want to hear your perspectives, and also at certain points to test if you've been paying attention. But this first poll question is really to set the context, and it's building on Anthony's remarks around shared sanitation. So if we can bring up the question. So, according to WHO UNICEF Joint Monitoring Programme estimates, how many people globally rely on shared sanitation facilities? You've got 3 options here. Is that number 200 million, which is approximately 4% of the global urban population, 390 million, or 570 million? Now, we're going to keep this rapid fire, so I'm just going to give you around 10 seconds to digest that and pick a choice. and that time is closing around now. So we can bring up the results, Michelle. Very good. So the majority of you have picked the correct answer. So 570 million people globally are dependent on shared sanitation. And you're going to hear through this session around aspects like demand, scalability. And what we want you to keep in mind as we move through is that shared sanitation is far from a niche concern. This is over 500 million people globally depend on these facilities and have no alternative, as Anthony outlined. So I think that provides some context on the relevance of this discussion in terms of scale and the number of people impacted. Okay, back to you, Florence. Thanks.
Great. Thank you, Sam, and thank you to everyone who participated in this first poll. Those insights, of course, set the stage very nicely. And now let's turn to the evidence. We begin with findings on the impacts of the intervention on pathogen exposure and child growth. It's now my pleasure to invite Joe Brown, director at the University of North Carolina. Joe, the floor is yours.
Thank you so much. It's a pleasure to be here. Thank you, everyone, for taking time this morning, this afternoon, this evening. I'd like to share with you, as Anthony mentioned, the results from the MapSan trial are very complex, and we've been working on both data collection and analysis of data for the last 12 or 13 years. So it's a long-term effort, but I'll try to be very concise. I believe I was given 9 minutes, so we'll see how far I get. Next slide, please. So to locate you in space, this is urban Maputo, Mozambique. So large parts of the city of over 2 million people are semi-formal or informal. These are informal, low-income communities, and shared sanitation is quite common in these environments. Next slide, please. So shared sanitation in this context among households that all share latrines typically looks like this: relatively low quality latrines that are constructed inside courtyards of compounds. So clusters of households that would all share this infrastructure. These latrines are often created out of poor quality materials. Often there's an unlined pit that receives waste. When these pits fill up, they can be desludged. Often the infrastructure is actually just moved to a new site within the compound, and space is at a premium in these areas. So there's not a lot of new ground to dig new latrines within side compounds. These latrines are typically poor at the primary function of sanitation, which is to contain excreta. Next slide, please. You can imagine under some circumstances, wastewater and sludges that should be contained in latrines are in fact able to be transported back into the living environment, especially when it rains. So the existing sanitation infrastructure there is relatively poor in terms of its ability to contain waste. Next slide, please. So to say a few words about the MapSan intervention, these are communal sanitation blocks that are custom designed for household clusters or compounds to serve the people living there with better sanitation. It's not just sanitation. I would like to just say that these interventions are multifaceted in terms of the amenities that are delivered to the people living there. So, for example, there's sex-segregated latrine cabins with locks on the doors. There's a hand washing station. There are ramps for access for people who are differently abled. There's a connection to the municipal water supply. There's rainwater collection. There's laundry. So these are quite high quality facilities that have many amenities to support environmental health for people. These larger versions of the intervention serve typically more than 20 people, and they can be custom designed to serve even more than that. So they can be much larger than this as well. Next slide, please. These also come in a more basic variety, which I'll refer to as shared latrines. These typically serve fewer than 20 people, so a smaller cluster of households. They lack some amenities, but they are much cheaper. Next slide. This is an aerial photograph of the city of Maputo, and it shows the intervention area. Intervention compounds here are denoted in red, these red circles, and control compounds, and I'll talk about the study design in a moment, or comparison sites that are not served by this new intervention are in sort of light blue. What we did in creating this study is we recruited households before any of these interventions were put in place across informal communities of Maputo, starting in about 2015. And as we recruited new households and clusters of households, we also recruited equivalent control compounds that would not receive the intervention, but that met all of the criteria for the intervention, and developed these two cohorts of clustered households, one that will be served by better sanitation and those that would serve as a comparison group. Next slide. So our question is that are children who are born into the intervention arm, those that are served by better sanitation, who get protection from birth, do they experience reduced pathogen exposures and improved growth over time compared to the controls? Next slide. So I'd like to say this is a very complex study design, and I don't have time to get into all the methodological details, but there's a QR code here, and you're welcome to follow this. This is a protocol paper wherein we set out the study criteria. Next slide. So our primary analysis is based on the analysis of stool samples. So our primary outcome in this trial was detection of pathogens in stools as a proxy for enteric infection. So this involved collecting over 1,000 stool samples from children under 5 in the two arms. Again, those with better sanitation and those without. Next slide. So I'm just going to talk about the 60-month study. So this is the very last time point where we went back and looked at all children who were born into both of these arms about 60 months or 5 years after the intervention was put in place. So again, we have these two arms, and you see we had a baseline and then several follow-up points. Next slide. So I want to talk about the growth measures first. Next slide. We saw a dramatic difference in growth between the two arms. So in purple are the intervention children, and in orange is the control children. And what you see here is a histogram, which is a distributional plot of the height for age z-scores. So this is an age-adjusted height or length measure of children as a measure of their growth. And we saw a 31% reduction in stunting that's attributable to the sanitation upgrades. And that's again from over 1,000 children. So these are very, very large, significant differences in growth that could not be attributed to anything else that we measured. Next slide. We also observed that children were heavier in the intervention arm as well. Less dramatically so, but still statistically meaningfully so. Next slide. If you break this down between those that are served by the communal sanitation blocks, the larger infrastructure, and the shared latrines or the smaller ones, what we have observed is that actually the impact is slightly greater in the shared latrines or the smaller compounds, the smaller infrastructure. That has fewer amenities but serves fewer people. And there's some insights here that I think we could maybe expand on during the discussion. but we do see the impact seems to be a little bit greater there. Next slide. So I want to talk about the pathogen results very quickly. Next slide. So if you compare pathogen prevalence in stool samples from kids across these two groups, and the green is the control arm and the orange is the intervention arm, across many different pathogens that we associate with sanitation, including Ascaris and Trichuris on the left panel, Giardia, as well as many of the pathogenic bacteria, we see a very large difference between these two arms in terms of their pathogen profile. This is exactly consistent with the differences in growth measures that we have observed. Next slide. We also see that in looking at the stool sample pathogen data, we see a similar trend in terms of the relative impact among those children served by the shared latrines over the communal sanitation blocks. Again, so green is the control arm, the communal sanitation blocks are in orange, and the shared latrines are in purple. And you can see we also see, for example, with Ascaris at the top left or Trichuris at the bottom left, we also see that the effects that we've observed are even more pronounced among the shared latrine children. Next slide. By the way, we also looked at fecal sludges. So we sampled the latrines across the two arms, control in green and intervention in orange. And we also see a difference in pathogen detection just looking at latrine sludge. So that's a measure of pathogens that are being excreted by all the people served by these two types of sanitation infrastructure. So that's really interesting to us because it means that surveying fecal sludges could be a potentially compelling way to actually test out the effects of interventions in this way, which is much cheaper and more straightforward than collecting stool samples from people. Next slide. So just a few observations in summary. We saw clear improvements in growth and fewer infections among kids protected from birth with this very high quality intervention. I should have stated too that these latrines also, they're septic tanks, right, where the solid material is very well contained. Some evidence that effects are more pronounced in the smaller compounds. Next point. And also environmental sludges or environmental surveillance is totally consistent with the enteric infection data. So taken together, this is, we feel, very powerful evidence that is very consistent across growth measures and the pathogen results. And this is also, we have not been able to explain away, and we've tried, these effects using any other differences between these two groups of kids. And we measured lots of things, including income and other aspects of environmental health. And really the major differences that we're observing, we feel are attributable to the differences in sanitation. And so we're very happy to have the opportunity to share this with all of you. Next slide. These are a couple of preprints. All of these results are in review currently, and we should see them soon be published. But we've also published a couple of preprints. So you can see there's one on stool pathogens or infections and one on growth. And I encourage you to have a look at those if you really want to dig into the evidence, or we can have time to discuss it a little bit later on the call as well. Next slide. This was a massive effort over more than a decade. There are many people, including people not in this image, that represent the huge team of dedicated people at CISPOC, at INS, our partners in Mozambique, as well as colleagues from WSUP and colleagues from London School of Hygiene and Tropical Medicine, as well as UNC. Edna Viegas, our local PI, is there on the right. And so thank you to all of these people. Next slide. Also like to express gratitude to the to USAID and to the Bill and Melinda Gates Foundation, which generously provided funding for all of this work over the years, and our huge team of students and collaborators here at UNC. So with that, I think I'll conclude my remarks. Thank you so much, and look forward to the discussion later on in the call.
Thank you so much, Joe. That was a powerful and an insightful overview of the physical health impacts of the study. But we want to take note that physical health is only part of the story. Sanitation also shapes dignity, safety, and daily lived experiences, especially for women, girls, and the vulnerable groups. And to explore this dimension of how the intervention also improved the quality of life and mental well-being, I invite Ollie Cumming, the lead environmental health group at London School of Hygiene and Tropical Medicine. Ollie, over to you.
Thank you very much, Florence. It's a really good starting point for my presentation. If you could go to the next slide. So you talked about remembering that sanitation is about more than physical health. So I'll start with part of a quotation and not merely the absence of disease. And I'll come back to the full quotation and I'll leave you guessing as to where that comes from. But I am going to talk, following on from Joe's presentation, about enteric infections and childhood undernutrition, to some of the broader impacts of sanitation on people's life and specifically quality of life. I would just like to acknowledge, building on what Joe had said, that for this study in particular, which is one part of the broader sort of MapSan trial, colleagues at the National Institute of Health in Mozambique, particularly Dr. Razul Nala and Dr. Edna Viegas, but also at the London School, Dr. Ian Ross, who completed a lot of this work as part of his PhD thesis. Next slide, please. Great. So thinking about how we measure and understand sanitation interventions, we put a lot of effort and energy often into understanding the attributes of the service, the quality of the infrastructure. We think about associated behaviours, whether facilities are being used. And then, particularly in epidemiological research, we think about the attributes as they relate to the users, to the people. And I've divided this up into two very broad blocks. So physical health, as Florence flagged in introducing these slides, which could be enteric diseases or undernutrition, like Joe talked about, but could be other diseases as well, like soil-transmitted helminths. And then the second block, which is quality of life, which is about experiences and feelings. So I'd like us to think about quality of life as focusing on what people themselves value, the attributes they value about sanitation. Next slide. So this diagram provides a conceptual model for how better sanitation, such as the MapSan intervention, might improve quality of life through influencing people's subjective or personal perception and or experience of disgust, privacy, safety, disease, and shame. And if those aspects are improved positively, we would expect the overall quality of life to improve. Next slide. The SANQUAL 5 index, and there's a great website if you want to sort of dig into this, is basically a sort of 5-item, sort of 5-question tool that can be incorporated within epidemiologic epidemiological studies, or indeed can be incorporated in routine sort of monitoring of sanitation program that measures sanitation experiences across 5 quality of life attributes, as I listed on the previous slide, and captures what people value about sanitation. The attributes, so the 5 attributes are weighted by respondents to derive an index. Those attributes in the index were developed through both qualitative and quantitative research conducted in Maputo as part of the MapSan study. And you can see the papers at the bottom of the slide. And just to flag, it's now been validated in a 6-country study. So we're pretty confident this is a tool that's ready for application across different settings. And indeed, it's been used by a number of operational and policy organizations. Next slide, please. I'm going to give you 2 sets of results very quickly here. The first is on the impact of the intervention on quality of life using the SANQUAL 5 index, as well as on mental well-being using a sort of well-established WHO tool called the WHO 5 Mental Wellbeing Index. You can see in the slide the paper if you want to dig into the details, but basically we enrolled 424 participants, split more or less equally between the 2 arms, the intervention arm and the control arm. And we collected data 24 months after the intervention, so a little bit different to Joe's results, which was 60 months afterwards. And we made a comparison between people receiving the intervention and the control group, and then we stratified that by the 2 facility types. And the results were that we found a big effect for both types of MapSan intervention, the shared latrines and the community sanitation blocks. And we found a smaller but still significant effect on general mental well-being. So quality of life specific to sanitation, we found a big impact, as we'd hypothesized. And even on general mental well-being, we found a smaller but significant impact, as we'd hypothesized. Next slide. Just related to this study, we'd also looked at the cost of the intervention. I thought I'd just quickly share these results because I think they're important in terms of policy and decision making. But these simple shared toilets were about half as costly as the sanitation blocks, but similarly effective on quality of life. And this is more or less similar to the results that Joe showed in terms of the enteric pathogen detection and stunting. It's worth thinking as well, though, that the sanitation blocks tended to, on average, be shared by far more people. And maybe the sharing or the number of people that were sharing may have modified those effects. But broadly, the cost per person per year in the controls, so the pre-intervention was about $3, about $21 for the shared latrine, and about $46 per person per year for the community sanitation block, even though the effects were broadly similar. Next slide. So in conclusion, we saw a large effect on sanitation-related quality of life using SANQUAL. We saw a smaller effect on general mental health well-being using the WHO 5 index. The effects were similar by facility type, but the costs differed. And quality of life, it's important to remember, reflects exactly what people themselves value. So in itself is a very important result when we think about mobilizing investment by households themselves. And the last point is that I think it's really important as we think about the evidence for sanitation that we assess all health benefits to understand the true value of sanitation before considering the costs. So the quote that I gave at the beginning is actually from the World Health Organization sort of constitution. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I think if you look at the results from the MapSan trial together, enteric infections, undernutrition, but also quality of life and mental well-being, you begin to see the full impact that sanitation can have on individuals and society. Thank you.
Thank you, Ollie, for bringing in that critical dimension. You reminded us that quality of life is ultimately about what people value. And of course, you echoed the World Health Organization definition of health. Now we've seen the evidence, and I think we need to take a look at what the delivery is, what the implementation was like, and what does it take to implement high quality shared sanitation on the ground. And with that, to bring in the practical and on ground insights, I invite Fatima Musa, the Public Health and Environmental Technical Officer from WSUP Mozambique, to share those reflections. Fatima, please go ahead.
Thank you, Florence. Good afternoon, everyone. I'm Fatima Musa.
Fatima, maybe if you could increase your
Can you hear me
volume
well?
a bit, because it's quite low from my end. I hope it's not the same for the rest.
Okay, thank you, Florence.
That's better.
Good afternoon, everyone. I'm Fatima Musa, Country Manager of WSUP in Mozambique. As my colleague Anthony presented, we are the implementers of WSUP. Next slide, please. So we delivered the high quality shared sanitation facilities, and I'll be presenting the WSUP's perspective as the implementer. So between 2015 and 2016, WSUP implemented the shared sanitation intervention program in Maputo City with the support of the municipality. Approximately 300 compounds. So we define compounds as groups of families that share the same space and also the same toilet. So around 300 compounds received improved toilet facilities across 16 neighborhoods in Maputo City. So we built shared toilets, as the one you're seeing in this picture on the right, for compounds with less than 21 residents. And we built communal sanitation blocks that are bigger infrastructures with more than one compartment for compounds with more than 21 residents. So as you can see, the existing pit latrines were replaced by pour flush toilets connected to septic tanks that are safer. Next slide, please. So here are some key features that we followed for the model implementation, starting from the site selection for the construction of the shared toilets that was based on a 12 criteria that was agreed with the municipality. Here on the right side, you can see some examples of this criteria. I'm not going to go into detail in every criteria, but you will receive this information. One of the criteria that is very important is the willingness of the residents to contribute for the construction of the infrastructure. That is very important because this leads them to have the ownership of the infrastructure, and is very important for the sustainability of the project, because after the construction, they'll be the ones that will have to take care and do the operations and maintenance of the infrastructure. And the selection of the exact location of the communal sanitation blocks were informed by the local leaders that was based on a needs assessment. The municipality also gave a financial contribution that was the provision of land free of cost. Another key feature that is very important for the model implementation is the water supply. So it is important that the locations have reliable water supply so that it's easier to maintain the hygiene on the wash blocks. And we also made sure on the designs the provision of ramps and separate compartments for the people with disability. And it was used an integrated approach involving the community for the hygiene promotion and also the monitoring that was done by the local leaders. A key feature that is very important is the arrangement that was done for the operation and maintenance. That is very important, that is highlighted here in this slide, and is very important for the sustainability of the project that I'm going to detail in the next slide. Next slide, please. So this is the model that was followed for the operation and maintenance of the infrastructure. So we created a sanitation management committee for each of the each compound that was composed by what will take care of the infrastructure and all the operation and maintenance. There was also support from WSUP in mobilizing demand and raising awareness. And WSUP also trained these committees. And this training was more focused on the use of the facility, on operation and maintenance, and best hygiene practices. The estimated cost for operation and maintenance is around $0.04 per day for the shared toilets and around $0.1 per person per day for the communal sanitation blocks. And Women Day adopted a central role in all stages of the process. They supported since the beginning on the discussions for the location of the toilets. They also were very participative in the design clinics, where they also gave their contributions for the designs of the infrastructure. They also supported during the construction and very important in the management after the construction. They are more than half of the sanitation management committees were women, where they also took leadership positions as the president and vice president of these committees, and they were the ones who continued to take care of the infrastructure and do the operation and maintenance. Next slide, please. So here are some learnings for future implementation. Government structures must be engaged in all stages of the process and display commitment to the improvements. There is a need for continuous community engagement to make sure that we reach the desired behavior change. High quality of facilities contributes to demonstration effects and mobilizing demand, and we have seen this in this intervention, that demand was there. The design clinics were very important. They supported to tailor the project to user preferences, and finally, it's important to take an integrated approach and make sure that there is reliable water supply, there is community-led hygiene promotion and monitoring, so that the project is full. Next slide, please. So we would like to thank again to the funders that made possible this intervention, to the World Bank and JSTF who funded the intervention, USAID and Gates Foundation who supported the trial, and an anonymous donor that for their support on the dissemination of the results, including the development of the MapSan website. Thank you very much. Over to you, Florence.
Thank you so much, Fatima, for connecting the evidence to implementation realities, and apologies for the mix-up of your title during the introductions. So we've now heard the evidence from multiple angles: child health impacts, well-being and quality of life, and as well as implementation. But would like to pause again to reflect, and I would like to invite Sam to take us through a second poll.
Thank you so much, Florence, and to all of our presenters. First thing to say is I mentioned that these polls are partly to keep you on your toes, and we planted a typo. I wish we did, but it was a typo in the first question. So that's just to say that it's 560 million people are dependent on shared sanitation facilities, but that's across urban and rural. But the point stands, over 500 million people dependent on these shared facilities. So moving into the second poll question, and I'm going to move through this again very quickly do your best to absorb this, but we want to just point some engagement. And we've heard about the range of findings from MapSan, and we'd like to hear from you. And what do you see as the most compelling of these findings for informing urban sanitation decisions? We've heard about the reduction in child exposure to enteric pathogens from this intervention, a 30% reduction in child stunting. We've heard about the connection between those health impacts and being born into the intervention compounds, which is significant. Improvements in quality of life and well-being, as Olimet outlined. We've heard program insights from Fatima into what makes an impactful shared sanitation intervention. And altogether, we've seen really strong evidence from a rigorous long-term controlled study. Really groundbreaking evidence, and fantastic to have evidence of this type to inform decisions. So I'm asking you to pick one of these. Of course, they're all significant, but which one would you highlight, which stands out to you? I think that's long enough. Again, this is rapid. If we can raise the results. The results flashed up. Yeah, thank you. Okay, that's interesting. So we're seeing quite a wide range there, with the reduction in child stunting as the most selected. But I think we take from these responses that there is so much to learn from this intervention and this evidence for us to build upon, and that sets a good foundation for the panel discussion. So over to you, Florence.
So thank you, Sam, and thank you all for your reflections. We move now to the panel discussion. This discussion will be in two parts. The first part is interpreting the findings, and the second part is leveraging the findings and how we can translate them into policy, investment, and action. So a quick note to our panelists: in the interest of time, we'll allow up to 3 minutes or less for the first intervention. Per intervention in the first part, and then 2 minutes per your intervention in the second part. Sam will help us to keep time to ensure we have a very dynamic and balanced discussion. With this lineup of panelists, while we already heard from Joe and Oli through the earlier presentations, we will also bring them back to get their perspectives into the panel discussion. I'd like to invite all the panelists to come on camera as we begin the discussion. To start us off, I would like to invite Sheila Simiu, research scientist at the African Population and Health Research Center. Sheila, your research has spanned public health, WASH, and nutrition, and you're an expert in the socio-economic dynamics of informal settlements. From a cross-sectoral perspective, what do you see as the significance of these findings for child health and the quality of life in these settings?
Yeah, thank you, Florence. I hope you can hear me.
Yes, I can hear you. Please go ahead.
Okay, great. Thank you. Thanks to the presenters that have spoken before me. And again, I want to also appreciate the opportunity to be here. And in responding to your question, I want to look at it from 3 ways. And I'll start with one of the health of shared sanitation, bearing in mind the lots of research that we've done.
Sheila, I'm not sure whether I'm the only one, but I'm struggling to hear you. Maybe you could turn off your video, probably. Can somebody else confirm whether they're struggling to?
Yeah, there's some interruption there.
Yeah,
okay.
She's breaking.
All right. Maybe we'll move on to Sonia as then we'll come back to Sheila. Sam, maybe you could help me follow up with Sheila on that.
Yeah. Thank you.
So I'll bring in Sonia at this point. Sonia Casimiro Trigo is the Public Health and Environmental Technical at the World Health Organization. Sonia, WHO has renewed its forecast on maternal, human, and child health. Can you share WHO's reflections on how this research can inform ongoing work at the interface of WASH, and maternal, newborn, and child health. Sonia, the floor is yours.
Okay. Thank you very much for the invitation. It is a real honor to be part of this panel. Firstly, congratulations to the team on this excellent, much anticipated study. As some background, WHO conduct extensive systematic reviews to inform the 2018 guideline on sanitation and health, and in 2019 provide additional commentary on the WASH benefits and China trials with a particular focus on the effectiveness of combined WASH and nutrition intervention. Overall, we find that WASH studies are often not very well described and offer limited intervention to subset of community with limited or mixed impact on health. In particular, the WASH the WASH and the nutrition studies found that select WASH intervention had no effect on child growth and only mixed effect on diarrhea. Factors may have contributed include incomplete community coverage, lack of continuous water through household connection, continual exposure to animal and child feeds, poor food hygiene, ineffectiveness of coordination against some key pathogens, and the short time between intervention and follow-up assessment. In that sense, it is likely that intervention failed to interrupt all pathway for contamination of the environment and thus systematically prevent human exposure to fecal pathogens. These finds were both surprising and frustrating for the WASH sector, given the well-established role of WASH in disease prevention and the clear understanding of fecal-oral transmission pathway. They are particularly concerning when such results are used to justify reduction in funding for WASH and integrate WASH nutrition program. At the same time, evidence from randomized controlled trials over the past 5 decades consistently shows that meaningful health impacts are achieved only when high-quality WASH interventions are delivered at scale with full community coverage and sufficient duration to create a clean environment for all. This is where the MapSan trial has been instrumental by applying a lesson from early study, delivering high-quality sanitation intervention across the entire community and allowing adequate follow-up. The trial demonstrates substantial health benefits. Children living since birth in intervention house were 31% less likely to be.
Sonia, just to let you know, that's 3 minutes. Sorry to interrupt.
Okay. Translating this evidence into systemic impact also requires strong primary health care system. Within a primary health care approach, WASH is a critical operation level and determinant of MNSCH outcome. Success depends on 4 core strategy levels: political commitment and leadership, robust governance and policy framework, adequate and sustainable financing, and meaningful community and stakeholder engagement. Without this foundation, even well-designed interventions are unlikely to achieve lasting or equitable impact. Thank you. Over to you, Florence.
Thank you, Sonia. Those reflections clearly reinforce the importance of integrating sanitation within the broader child health and public health agendas. Of course, you've reiterated the importance of the foundations, having the enabling environment for that to happen. Thank you. And I'll get back to Sheila again. Sheila, I hope your audio is better. I'll repeat the question quickly. So Sheila, your research research has spanned public health, water, nutrition, and you're an expert in the socioeconomic dynamics of informal settlements. From a cross-sector perspective, what do you see as the significance of these findings for child health and quality of life in these settings?
Florence, I hope you can hear me now.
Yes, we can hear you. Thank you.
Okay, thanks. Sorry for that. I think I'll go straight to my reflections, and I'll talk about three things. The first one being the operation and maintenance, or the how of shared sanitation. And we all know that there have been discussions about the place of shared sanitation as we classify sanitation and how it should be classified or categorized, bearing in mind the risk that it poses in terms of exposure to fecal matter. Yet, we are also aware that shared sanitation is used by a high percentage of residents, mostly those living in low-income areas. And so what these results highlight is the role of shared sanitation in improving overall health and how it should work well to improve health. For example, we see the how that has been highlighted by Fatima's presentation. How can shared sanitation work? And the answer here is partly about local governance and operation and maintenance of shared sanitation. And if we are able to get that right, it means that we can have shared sanitation facilities that remain clean and usable for all. So that's the first reflection. The second reflection is from Joe's presentation, and it's about the impact on child health. And we've seen the huge reduction in stunting in compounds that had improved sanitation facilities and the lower occurrence of pathogens. So what these results really highlight for me is the importance of setting the foundation right for child health and development, and ensuring that we need to improve environmental conditions, especially during the first years of life for children, because they actually set the foundation for later life and for overall child health. And then lastly is what Oli has presented about the quality of life. And what we have observed is a general improvement in the quality of life, and with a focus also on mental well-being. And what these results for me signify is the interconnectedness and all-roundedness of life and quality of life. What the results have shown is that shared sanitation contributed to well-being and subsequently to overall improved quality of life. And as we also take into consideration the overall well-being and the definition of health, we then need to think about, we need to take a pause and ask ourselves, what is really the value of sanitation that we almost always miss? And I submit that sanitation has a huge impact on individuals' lives and well-being, and I'm using that very specifically on lives and well-being. And most of this may not necessarily be physically and directly tangible, or they might seem minute, but they play a very critical role in our daily lives and in our overall well-being and our quality of life. So those for me stand out as some of the most crucial results and some of the significance of these results overall. Thank you, Florence.
Thank you so much, Sheila, for those reflections, really. I'll now turn to Najib Bateganya, who is the Deputy Director, Water, Sanitation and Hygiene at the Gates Foundation. Najib, prior to joining the Gates Foundation, you served as Deputy Director for Sanitation and Environment for Kampala Capital City Authority in Uganda, a city with high prevalence of shared sanitation. What do you see as the key takeaways from this study for the city authorities mandated to provide sanitation and other basic services? Najib, the floor is yours.
Thank you, Florence. In the interest of time, I'll not talk about the Gates Foundation. I'll go direct to your question. So one, the city authorities are at the center of implementation, and I think at that position, they have the opportunity to really integrate inclusive and equitable services across sectors. Of course, we all know that, especially in low-resource contexts like in sub-Saharan Africa, the urban authorities struggle with huge infrastructure and service backlogs, and that stretches resources across sectors, and of course, prioritization becomes quite tough. Sanitation, most of the time, of course, is under prioritized, under financed, and hardly gets into the urban planning and financing framework. So evidence like this, and I'm really super excited about Mozambique. I have worked with a couple of partners, World Bank and others within Mozambique, who are advancing sanitation, building on this kind of evidence. So evidence like this is critical. One, it integrates data and evidence-based evidence-based decisions into planning frameworks, regulations, and standards that drive sector improvements. For example, in Kampala, we realized, unlike in Mozambique, we built onto research and academic partnerships to build evidence that enabled us to design minimum standards for sanitation systems, and those guide across sectors, education, health facilities, communities, to be able to deliver services that are safely managed across communities. And also, building on such foundations, you are able to then attract partnerships and collaborations, like what you see here. You see WSUP coming in and other NGOs building on such evidence to be able to tailor solutions to real context on the ground, but also focus on service outcomes that best drive impact within communities. So this type of evidence is really critical. I urge you all urban authorities across, especially low resource contexts, to be able to work with researchers, with universities, to be able to inform how they plan and deliver services across their municipalities. Yeah, I'll pause there in the interest of time, but exciting work, and I think many partners are able to draw from this to elevate the level of sanitation service delivery across urban areas. Thank you.
Thank you so much, Najib. Particularly valuable to hear your strong reflections from the city authority perspective, reinforcing that city authorities are at the center of integration of urban services. Thank you. And Najib, we'll bring you back towards the end of the webinar. Yeah, just to note. I'll now move on to bring Tanvir Ahmed, a professor at the Bangladesh University of Engineering and Technology. Tanvir, a key question here is the transferability of these findings across countries and regions. The MapSan findings speak to the context of low-income communities in Maputo, in Africa. What are your reflections on transferability of these findings to South Asia? Would there be value in adapting the study to this context, and what contextual differences would need to be considered? Over to you, Tanvir.
Sure. Thank you for the question. I think there's a great deal of similarities in the context in Maputo, like in sub-Saharan Africa and in the South Asian. Especially in both these cases, we have rapid urbanization and the low-income community residents are gradually increasing. So population living there is increasing. So maybe in future, we'll see a large number of limited or shared sanitation installations as we see a gradual decline in open defecation and unimproved sanitation. There are also similarities in infrastructure and how these low-income communities are organized, how the O&M, there are some similarities in the type of toilets and how the operation and maintenance and the cleaning is carried out. But there could also be some dissimilarities in context. For example, in this case, we see that there could be issues with land tenureship. Since in these low-income communities, a lot of people live together, and the dense population, and most of them, they don't have land tenure. So how will that affect the willingness to pay? Here we had some willingness to pay, but like in many South Asian contexts, there is no land tenure. So that might be affected. How the local government in that area is enthusiastic about these shared sanitation facilities installation and be involved in the operation and maintenance, that could also be an issue. We also need to, there could be some geographical issues as well. Here in this context, we see that you've used septic tanks with soak pits, which worked very well. In many contexts, soak pits might not be working, and you need to adopt different sort of excreta management systems like dislodging. So other services might be involved over there, which can definitely increase the complexity. However, I think that the reason why we are discussing here that these limited or shared sanitation facilities, there should be an opportunity for these to be graduated into either improved or safely managed sanitation status. And for that, we actually need very clear and defined service level standards. We talked about how public health can be improved with proper sanitation facilities. And we see also from the second presentation that the quality of life, mental health, well-being, these can also be improved. But in different contexts, there could be certain differences which might affect these outcomes. For example, when you talk about privacy, safety, security, or even accessibility to these toilets, this very much depend on the location or how densely people are living together. Shared toilets, in this case, you design it for 21 residents, or maybe some other models could be higher. But that kind of standard might not be followed everywhere, and there could be differences as well. Also,
Tanvir, that's 3 minutes. Sorry to interrupt.
Oh, okay, sorry. I'm finishing up. So I think these subtle differences are there, and what we need to do is actually we have for each country they need to define what the service level indicators will be, and for the shared sanitation and limited sanitation options, we need service level standards, and that with that we can go probably a long way further. Thank you.
Thank you, Tanvi. That South Asia lens is extremely important, particularly as cities across regions grapple with similar urbanization pressures. But of course, you've highlighted the importance of standardization of service level across the different contexts and regions. George, I'll come to you shortly in part 2 as we shift to policy, investment, and financing implications. But before we close this first segment, I'd like to return to Joe Brown for some final reflections on interpreting the evidence. So Joe, these findings are nuanced. For WASH stakeholders, what do you think should be the main takeaways for informing sanitation provision and informal settlements? Are there claims we can confidently make based on this research? And are there conclusions you would guard against? Over to you, Joe.
Yeah, thank you, Florence. I would say, to be quick about it, I would say, I think this evidence definitely raises the conversation around shared sanitation into a new place. I think we need to be considering shared sanitation of certain types to represent high quality sanitation that can improve health outcomes. That's very clear. I would also like to just briefly reflect on the differences between this evidence and this trial and other large trials of sanitation that have happened recently. So you may all know about the WASH benefit trials as well as the SHINE trial. And there have been others. This is really the first high quality controlled trial of urban decentralized sanitation. So it's an urban high burden context. The other differences are it's a very high quality intervention compared to previous interventions in sanitation. So these are not simple latrines, they're complex infrastructure. And though they are quite expensive, the cost per person per day is very low, as I think you've heard. And perhaps Ollie can expand on that. So it's very high quality compared to other sanitation interventions. And also adherence was very, very high. So as some of you may know from other health impact trials, you can build latrines, you can provide latrines and other infrastructure, but that doesn't guarantee use and that behaviors have changed. In this context, and WSUP could expand on this model, but basically the old latrines that people were using are physically dug out and taken away, and the new facilities replace them completely. That's a very important point because it means that adherence to this intervention was very close to 100%. That is to say that the new infrastructure was used by everyone within these compounds. And I think that's the kind of transformative intervention that we really need to see. I mean, it represented really a massive difference in the sanitation infrastructure for these compounds and resulted in a massive difference, we believe, in exposure and potential for differences in health outcomes as well. So, I think this study design is complex. It's long-term as well, enabling us to capture those full life course exposures and outcomes for children. These are not things that can be measured in 1 or 2 years typically. So there are a lot of differences, around the study design and on the context and on the intervention itself that I feel really set this trial apart in terms of its potential value in moving the conversation forward around the roles of sanitation and supporting public health.
Thank you, Joe. And of course, for those reflections and also to our panelists for their reflections on interpreting the findings. And also thank you to all our participants who have shared their questions in the Q&A box. Please keep the questions coming. And thank you to the responses that have already been provided for some of those questions. But in the interest of time, we'll now move quickly to part 2 of our panel. And really the next question is equally important. How do we translate this evidence now into action? Yes, a quick reminder to our panelists looking at our time. We're really way above, above the time we've been allocated, but we hope we can still work within the remaining, I see about 12 minutes to the end of the webinar. So a quick reminder to all the panelists, please keep your responses and interventions to 2 minutes or less. So to kick us off, I'd like to invite George Joseph, the senior economist for Eastern and Southern Africa at the World Bank. George, you have extensive experience with the World Bank working at the intersection of sanitation and health in Africa. Can you share your reflections on these findings and how they could inform IFI investments to support sanitation and child health? Over to you, George.
Thank you. I hope I'm audible enough.
Yes, you are.
Thank you. Thank you for this opportunity to be in the panel today and speaking to such an august audience. And indeed, these presentations, wonderful presentations, and thank you for sharing these with us. And as many of us have been waiting for these results, particularly after the rather less inspiring results that we had from the WASH benefits and SHINE trials, despite a bulk of evidence from the observational studies. So this is indeed great to see that there is significant impact on stunting and quality of life. I'm particularly fascinated to see the quality of life findings because because this is something that we have been exploring also when we were considering the impact of 24/7 water access in some places in India, some cities in India, and we could see significant impacts on the quality of life. As they are subjective indicators, but still quite useful. So we have to think about, so that gives us a room for thinking about impacts at a much broader level. And the stunting impacts, of course, are quite valuable, which is about 30%. To me, it is a little high on the higher side, but happy to see the results coming out from such a rigorous setup. Now, coming to the World Bank context, as you know, the World Bank has had announced a Water Forward, which is one of the flagship initiatives that the bank is taking forward as part of this changing environment. The spring meetings recently announced that. This is also very much tied with the job agenda, and we know that sanitation interventions and the results like that we have on stunting shows that sanitation interventions will improve the human capital through improving the cognitive capacity and education outcomes and so on and so forth. So this is indeed quite fascinating to see these results coming out. And we also know that there are high multiplier effects of sanitation investments, particularly in developing country contexts. So again, that also calls for more investments in the sector, in the sanitation sector. So this is indeed fascinating that we have more and more such results, rigorous results coming out. But in the context of sub-Saharan Africa, we know that 80% of the urban population in the coming 2 decades are going to come from sub-Saharan Africa. And 7 out of the 10 fast urbanizing countries are in the region. Some of the megacities that we have, like say Addis Ababa or Dar es Salaam and so on and so forth, are growing very fast. And most of this is unplanned and with limited infrastructure expansion. From some of the studies, about 13,000 urban agglomerations, in the 90% of them are less than 300,000 population. That means the urban growth in sub-Saharan Africa is happening mostly in the small and medium towns. Of course, the big cities are growing as well. So there's a challenge that we are facing in terms of the urban growth. And there is and cholera incidence, again, cholera and such waterborne diseases, the incidence is much more in sub-Saharan Africa. 80% of the reported cases are coming from there. So this is again calls for more sanitation investments, and that is something that is quite lacking, in fact. And we know that sub-Saharan Africa is in fact lagging far behind in terms of they have to spend about 17 times more of their current spending to reach the current the expected or the levels of access.
Just so note that's now, coming up to time, George. Sorry.
Yeah. Okay. So now what matters again? Let me just conclude just 2 minutes on 1 minute on the last few points on why do we care? Again, it's important. It's quite fascinating to see that relatively low cost interventions like the shared care sanitation addresses some of the challenges that we face in urban contexts and planned urban contexts like land availability and so on and so forth. So here, this is important. This is interesting, but we have to think about the discrepancy or the change the JP definitions on safely managed water. This is a discussion for beyond the SDGs, right? How do we think about it? But implementation is the key, which many of my fellow panelists have talked about, and we have to perfect the science of implementation. Can we assure the quality of service? Can we have the combination of investments taking place here? Can we ensure that this could happen at scale? And the issue of scale, whether we can have large government-led programs considering the needs, be implemented with such interesting and such effective results. As the famous economist John List calls a voltage effect. Can we really implement this at scale? I have concerns on that, particularly there's a possibility when we think about the scale, the generation of false positives due to unique and often advantageous conditions present during the pilots. So we need more replications in different contexts, which Tanveer and others also mentioned about. We also have to see whether these pilot sites are quite unique and populations are quite unique. Are we catering to the broader target groups? If it is, so with limited randomization, we need more replication. So that's the other point that I want to mention. And sustainability of these interventions and the reliance on scarce resources, including skilled personnel, subsidized inputs, and emission mode, and so on and so forth. Can we sustain it for a long time? And can we sustain can we do sustainable behavior change at scale? Right? So that's another question, right? So because this kind of interventions, particularly the management of these facilities, is a challenging problem, and so needs to think about how do we do the behavior change better. And there could be other spillover effects if we are thinking about large scale doing these interventions at scale. And also, if when we think about scale, will the cost remain the same at such lower levels? Will that go up as well? So these are some of the concerns when we think about the scale. And let me stop here. Thank you.
Thank you so much, George. That investment perspective is quite critical for us to reflect on, particularly as cities seek evidence of cost to justify scaling inclusive sanitation approaches. And of course, you've highlighted some concerns that we also need to reflect about the importance of replication of such studies and so on. So thank you so much. We'll now move, and just as a request to our participants that you bear with us to finish this, maybe give us a couple of minutes, even beyond the scheduled time. I'll move on to Oli. Oli, let's turn to the global advocacy dimension. You were part of a team of authors of a recent opinion piece in PLOS Water, advocating for high quality shared sanitation to be recognized as an acceptable service level in post-2030 global monitoring frameworks. How should this research then inform global advocacy efforts on shared sanitation? Oli, over to you in 2 minutes.
Yeah. Okay, I think I'll just say two things. Number one, we should be careful about giving the Joint Monitoring Programme too much of a hard time. They've got a really difficult job to do in terms of interpreting global targets and connecting that, coupling that with sort of national data, national norms and standards and approaches. So I'd like us to move away from shared sanitation in or out in terms of those sort of global normative standards, and think much more at the national or the local level and in this specific context. So Maputo has a citywide sanitation plan. It's a long-term sanitation plan, which is exactly what's needed to improve sanitation conditions at the scale of a large city. And the intervention that we evaluated and WSUP delivered in collaboration with the World Bank is part of an incremental long-term strategy to move everybody to the best possible sanitation service. And my view is, as a researcher, as an epidemiologist, looking at the health impacts, that this intervention did exactly what we would want it to do. So it safely sequestered human waste, prevented infections that Joe presented, and the consequences of infections, undernutrition. And critically for the users, it showed a marked improvement in the things which they value, which is representing the quality of life. So I would say shared sanitation, such as the MapSan intervention, does have a really important role to play in very challenging urban environments, and is part of longer term incremental change, which could be expressed as sort of progressive realization, or I would say from a public health perspective, incremental risk reduction in populations. Yeah, so I think it's very exciting and very compelling evidence for that. Over. Florence, I think you're muted.
Florence, you're on mute.
From my end, I'm unmuted. How about now?
All good now.
How is it now?
We can hear you now.
Okay, great. Thank you. Thank you for that. So coming back to Sheila, APHRC works at the interface of research and policy. So how should these findings influence policy? What would be your advice for ensuring that these findings reach decision makers involved in sanitation, child health, and urban development at the national and city levels? Sheila, if you could just give us your intervention in 1 minute or less. Thank you.
Thank you, Florence. I'll try to be very brief. So, as you rightly say, I think I would look at it as influence on policy and practice. So I think the first thing I would say is it's important to identify who. And who here means we've seen the interrelatedness of different disciplines that have been part of the MapSan study, for instance. We've seen urban developers, economists, public health. So we need to identify who, not forgetting the community stakeholders, because they are an important decision maker and they are an important stakeholder. Then we also need to identify the how. How do we engage these stakeholders so that then the results can be taken up for policy and practice? One way is what we are doing today, which is this webinar. And we also need to identify, as we engage these stakeholders, what language do we use? For instance, someone from finance needs to understand what's the return on investments. So packaging this in a way that is understandable to all different stakeholders. And finally, which is something that has been mentioned before, is the issue about policies and guidelines. And at a national level, we need to come together as stakeholders and craft out or design or write out these minimum criteria or minimum standards at the country level that can then feed into the global and regional level. I think back to you, Florence. Thanks.
Thank you, Sheila, for those practical guidance, of course, on how we can bridge evidence and policy influence and, of course, implementation. I'll now quickly move to Tanvi. ITN BUET is a leading voice providing training to city authorities in Bangladesh and supporting citywide inclusive sanitation. For the citywide inclusive sanitation practitioners on the call, how can we engage sanitation stakeholders with this evidence to influence investments and plans at national and city levels? Tanvi, if you could share your views in a minute or less.
Thank you. Thank you. I'll be brief as well. I do see a lot of literature citing that development partners may not have the appetite to invest in shared sanitation because they do not contribute to improved or safely managed sanitation. I think that is half true, because development partners when investing, they depend on the viewpoints and the policies of the local government and the national government when they want to prioritize investments. What we are seeing today is that the national governments in different countries are promoting citywide inclusive sanitation and emphasizing fecal sludge management in their policies, directions, and new investments. Same here in Bangladesh, because when we see development partners investing in sanitation, they're investing in sewage infrastructure, but they also have components in the low-income communities. The public toilets are now designed with gender-sensitive focus, and investments in municipalities are already including components on DWATs and other things, along with shared sanitation. So it's all about how the national government looks at it, and their policies actually take preference and while designing this. Many things in the sanitation quality of life experiments that we've seen in the MapSan trial are already tied to the citywide inclusive sanitation framework, like equity, gender-sensitive sanitation, safety in public places, and things like that. So as long as we are promoting citywide inclusive sanitation, which has been prioritized in many national governments, which has been prioritized by development partners and etc., so when these investments are done following a CWISE framework, many of these aspects in the low-income communities, in the shared sanitation spaces and public spaces, and these sanitation investments will always be advocated like that. So that's how probably we want to engage stakeholders to influence these type of investments. Thank you.
Thank you, Tanvi, for those reflections. And again, I'll quickly move back to Sonia. building on that from the global health perspective, WHO is an expert in disseminating evidence and sector guidance to support evidence-based policy interventions. So what would be your advice to the sanitation sector in leveraging this evidence to influence policymakers and funders involved in maternal, newborn, and child health? Sonia, in a minute, if you could just highlight key points.
Thank you for the question. To leverage this evidence effectively, the sector should move beyond the debating where WASH works and instead of demonstrate when, how, and at what scale sanitation deliver health impact. WHO evidence shows that mixed results from the past trials reflect implementation limitation, not failures of sanitation itself. When sanitation is high quality, community-wide, sustained and integrated within primary health care, it contributes to reduce fewer infections and improve the early childhood outcome. Framing sanitation as a core determinant of MNCH, aligned with global commitment and supported by strong system, governance and financing, it is essential to mobilize sustained political and financial support. Thank you. Over to you, Florence.
Thank you so much, Sonia. And finally, let me return to you, Joe, for some closing reflections from a research perspective. Looking ahead, what do you see as priority questions for further research in this area? What questions remain unanswered that can support sanitation and child health in Africa and globally? Over to you, Joe, in a minute or less.
Thank you. I'll be brief. I think, one of the main questions I have is whether these results can be replicated in other contexts, whether we also see similar effects, including via randomized designs. And one of the things that was raised in the Q&A was, how should we think about the relative impacts that we were able to measure here in Maputo among shared latrines, shared sanitation? How does that compare with individual household latrines as well? So just from a research perspective, those are questions that I think we can pursue. I mean, I think overall, though, I think that where we are with evidence in this space is that we have enough evidence to take action. And I think that message needs to be clear from the research community as well as in the policy and advocacy community. These are interventions, I believe, that are ready for scale. And I think the thing that is most needed is investment and in expansion of our programming to serve the people who desperately need it.
Thank you so much, Joe, for that. And that brings us to the end of segment 2 of the panel. Again, thank you to all our panelists for all your reflections in both segments. And now, as we wrap up, I'd like now to invite Najib from the Gates Foundation for some closing reflections. Najib, over to you.
Oh, thank you so much. I'll be quick. I think Joe summarized my takeaways from evidence to action. At the center of the Gates Foundation mission, we are super excited about this work. Why? We pursue 3 goals. 1, elimination of infectious diseases, making sure that we significantly reduce maternal and child health mortality, as well as expanding economic opportunity, especially for those very vulnerable communities across the world. This evidence is strong. One key action point I can mention here is Mozambique, Maputo, and other government of Mozambique is taking these results to practical action. We know, for example, DINAS, the Department of Water Supply and Sanitation, and Ministry of Health expanding safely managed sanitation services across cities, across health facilities, and there is tangible impact there. For those who are in Mozambique can testify to that. At the Gates Foundation, we continue to see, and based on the results we see here, shared sanitation can be safe if we deliver the standards, the required standards and facilities accompanied by efficient operation and maintenance. And that's why working across the world with a number of partners, we are advancing solutions, technologies and service models that can advance services that eliminate pathogens, especially at household level, at community level, at urban scale. And I think for me, on Joe's point, this could be the next level of ambition. How do we move from this evidence? We know sanitation delivers health outcomes, but are we able to scale solutions, technologies, service delivery models that actually eliminate pathogens to maximize impact and health outcomes? I want to thank you all. I really congratulate our partners who participated in this work. And I agree with Joe. We need to replicate this across countries, especially in the global south, but also continue to build very strong partnerships with the global north across research, practice, and implementation at scale. Thank you so much.
Thank you very much, Najib, for those very powerful and forward-looking insights. And you've really also highlighted how this evidence aligns with the strategic focus of the Gates Foundation. And of course, you've posed questions for us to also reflect on how do we move forward from this evidence, aspects that have already been echoed before during the discussion. Replication and scale-up is something that we need to really reflect on moving forward. And with that, we come to the close of today's webinar session. Thank you once again to all our speakers, participants for joining us today and for your active participation. Today's discussion has really reinforced a critical point that shared sanitation is not inherently the problem, but quality is. And so if you can focus on quality and standards of shared sanitation, I think we'll be able to address some of the challenges of urban sanitation, especially in low and income urban settlements. We now have, of course, stronger evidence that well-designed, well-managed sanitation can deliver real health and well-being benefits. Thank you once again for joining us. We extend special thanks to, of course, WSUP and the APHRC COS network coordinated by ESAWAS for hosting such an important webinar, and also for giving IWA, the International Water Association, the opportunity to moderate this session. We look forward to continuing this conversation and working together to advance inclusive, evidence-based urban sanitation. And a quick reminder to our participants that the slides and the webinar recording will be shared afterward. But for more information and updates on the MapSan trial, please sign up to the WSUP newsletter and follow WSUP on the social media platforms. And also there are some contact information on the screen if you want to get more information. Once again, thank you. Until then, take care and let's stay connected.
Thank you, Florence. Thanks, everyone.
Thank you all.
Thank you. Thank you.
Thank you.